Cry It Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
Today's podcast episode is Fertility Fact Check, and it's busting myths and uncovering truths. Welcome to Cry It Out Loud, the podcast where we uncover the real world truths around living with fertility loss and baby loss. We debunk the myths surrounding maternal health, infertility, birth trauma, baby loss, and more. I'm your host, and today we're diving into the world of fertility, separating facts from fiction with an expert who's dedicated her life to helping women on their reproductive journeys. And joining us today is Dr. Allison Groff, MD, a board-certified OBGYN in Maryland. And Dr. Groff is here to share her expertise, breaking down the most common and misunderstood fertility myths that I think all of us have heard at one point or another that are tuning in. Whether you're navigating infertility or simply seeking the facts, this episode's for you. Welcome to Cry It Out Loud, Allison.
Thank you so much. It's such an honor to be here and to be able to share some of the experience and knowledge that I've gained in my line of work. And I just hope we can help explain some things and answer some questions that are helpful to your listeners.
Absolutely. And it's so nice and wonderful to have you just to talk through and process, different things with fertility, especially when you're starting on the overwhelming journey.
Right.
So,
yeah, absolutely.
Yeah. So, Allison, for our listeners, please share a little bit about yourself with us.
Yeah. Well, it's such a pleasure to be here. As you said, I'm a full scope OBGYN board certified. I've been doing private practice for 10 years. But I will say that before I even went to medical school, I did work for a year at the National Institutes of Health with a special population of patients who had primary ovarian insufficiency. And so I spent a year and I actually looked at more of the psychosocial aspects, what it felt like to get that diagnosis, and how, and looking at the communication between the medical staff and the patients. And so it was really, I learned so much from the women who were going through this experience. I have a special interest in psychosocial aspects of health. I did a master's also before medical school in behavioral science and health education. And I'm really a big fan of health literacy and attacking that misinformation or just countering it with the opportunity to get evidence-based informed information. And I host my own podcast, HerHealthMD, which is all about women's health and just evidence-based information.
Absolutely. Oh, thank you for sharing that, Allison. And it's, having someone who is compassionate, understanding the psychosocial and also the behavioral mental health aspect of these types of traumatic losses, the PTSD associated with them, and especially, the reoccurring loss that fertility is. It's just wonderful to have providers out there as yourself who is passionate about this and wanting to help beyond what you're doing in the office scope of things.
Sure. Yeah. I mean, there's just, the office is so important, but also just having information that people can trust, available and accessible.
I know, because especially, with trauma, it's fueled by, shame, guilt, blame, and all of a sudden you're going down Google deep dives, at 2 a.m. when you can't sleep and things like that. And you're getting misinformation. So then you're even more overwhelmed because you're like, okay, this source is saying this one's here, and they could or not be trusted sources, and you just don't know. And it really is. Yeah.
Absolutely. I totally agree.
Yeah. So having a provider that you can go to, you can talk to, it's just so important in that trusting circle of your providers all around you.
Right. Yeah. And sometimes it's even more important knowing, even if the provider's not the absolute expert in any given thing, if they can help you because they can give you accurate information and you feel like you can trust them, it can be a great starting point.
Yeah.
So finding that doctor, a nurse practitioner, or somebody that you really trust who is really encouraging accurate information and sensitive to how traumatic this can be is really the most important thing.
And I think too, Allison, I mean, you can probably talk to this, but the way that my parents were, when they were younger, going to the doctors, like what the doctor said was pretty much okay. That's it. Like this is
Right.
it, and you accept it. And
Yeah.
now, with millennials and those coming up through the ranks, and going to their doctors, they almost, wanting more answers, being explained why, just like those couple minutes and taking that extra time, because just being told this is how it is, or because I said so, it just isn't the way it is anymore with medical. And we almost have to be our best advocates for ourselves, just to feel part of our care and control.
Yeah. I think that's true. I think that we're living in this age of information where there's just constant information coming our way. So we have like social media and our news outlets. If you subscribe to them, it'll pop up every couple minutes with an update. And yeah, it's just constant. And we don't even know where to put our intention sometimes. So, I mean, it can be overwhelming. And so when you go to the doctor, you want to have the opportunity to ask about this information you've been exposed to, because the reality is we've all been exposed to it, but it's also awkward because you don't want to like challenge the doctor or make them feel,
less than, because
right.
are definitely more credentialed than I am, right? So
Right. But you have specific questions because you're not coming at it with no knowledge or exposure, or you're not coming at it with like what you said, like our parents and previous generations who just had, maybe their neighbor said, oh, my friend had this, or, you have a lot more because you have the access to so many people's stories, because like we have social media and we have just so much more communication than we used to have with the rest of the world and people far away.
Agreed. And like, I think that's why, we're so big on connecting people with lived experience, or those that are living in this world every day, right? Like for yourself, Allison, studying and, getting up on and treating our survivors every day. And then also, from the peer to peer, you do want to hear from those that have walked this, what was their experience, what they decide to do, just so then you can almost formulate your own way and your own path, but hearing all of the options and just getting it all. Because this is so consuming when you want to become a parent and all of a sudden you're hearing all of these myths and things being thrown at you, unsolicited advice, relax, take a vacation, things like that, that just really during those moments aren't helpful, but they're trying to take that pain and, that distress that you're feeling from the experience, emotions away. But in all reality, it makes you shut down and almost isolate and feel alone.
Yeah, that makes sense. I mean, that there's a lot of people who will want to help, but they won't know what to say, or they'll say the wrong thing. And then, you just want to stay up to date on things. And you just, maybe you don't even want to deep dive that Google search right now. You just want to watch the morning news, and reproduction's just coming at you nonstop, even when you're just watching the Today Show or something, so, I mean,
it's everywhere.
It's really hard. Yeah.
It does. It comes at
and
you.
Being able to, you're going to have that information exposure, even when you're not doing a Google deep dive, even when you're not doing like an intentional deep dive, like you're getting these constant exposures. And also, even if you are, because you're really seeking information, just feeling that you can come and you can ask those questions. And I think one of the things I would say is bringing, just as long as you're asking them openly, I'm curious about this from a place of curiosity. I think most of us are going to want to engage with that, and we understand that you're hearing information.
Absolutely. And it's like we said, with Fertility Challenge specifically, I think when we like get diagnoses as, unexplained infertility or things like that, we have to find the empowerment within ourselves, or whatever that looks like for our journeys, because we're all so different, with empowering ourselves to advocate for the care we deserve. And, the seriousness and the demand of it, with this being a medical condition, it deserves the same rigorous attention and respect as any other disease. And I think now, like you're saying, within the news, it's starting to really, those keywords are really starting to pop up, and, with women, maternal health and things like that. So when you're equipped with the right information and ask the right questions, push for comprehensive testing, ensure you're receiving optimal care, it's all about like shifting the narrative from just keep trying to really addressing the root causes and advocating for solutions. Let's talk about like why this shift in perspective is so critical for our listeners, that they can take their first steps and towards becoming their best own advocates in this situation.
So I would say, if you're first coming in, like you've been trying to get pregnant and it hasn't been happening, and it's like a first visit to your OBGYN, then they're going to go over the things that we know can affect fertility. So the most common things that you're going to get asked are going to be about your periods, if you're having regular periods, and how long you've been actually trying to conceive. And that can be different because, for me, like I'll have some patients who have been off birth control for a while. I've had a patient who said, oh, I've been off birth control for 2 or 3 years, but I just started trying. So, but other patients would, say I'm trying because I'm off birth control. So there's variations in what people perceive to be trying. But I would say that one of the things will be how long you've been trying to conceive, meaning how long you've been having regular intercourse and have not been on birth control. And then also, are your periods coming every month? So those are going to be the big things. They're also like what the history is. If you've had a pregnancy in the past, if your partner's had a pregnancy in the past, those are going to be important things that they're going to ask. And when we talk about monthly periods, what we're really looking for is, does it sound like you're having regular ovulation? So it doesn't necessarily mean that the first day of one period to the first day of the next is every 4 weeks exactly, or that it's, something at the first of every month, or something where it's a calendar month exactly. But it should be somewhere between 3 to 5 weeks from the first day of one to the first day of the next. So that's going to be kind of part of the assessment. And then looking for other things that we know for sure affect fertility, like if there's been a prior pelvic infection, if there's some of the behaviors that they might ask about would be like cigarette smoking, because it can slow how fast things move through the fallopian tubes. And if the partner does, because it can affect how fast the sperm can move. So probably just a generic history that's focused on things that can affect fertility.
Absolutely. And would you say too, Allison, as long as there's no other glaring issues or anything like that, like if a couple is really actively trying, it's really good to go in with either like an at-home testing kit that you've been doing for a couple months, just to show like, are you regular, right? So I use the Free Mom ovulation kit because it came with the app for free or whatever. There's a bunch out there, whatever you choose. But I really looked at it for like a 6-month time frame and went into my OBGYN with it. Like, this is what I'm seeing and things. And they were it seemed very appreciative with that, my doctor at the time. But is that something helpful too, if somebody did the at-home testing?
That can be helpful. My biggest thing that I like is a menstrual calendar, whether it's, you just wrote it down. Yeah. Whether you just wrote it down like in your calendar, or you tracked it with an app in your phone, whatever's comfortable to you. But if I can see for example, the last 6 months of when you got your period, even without necessarily the ovulation test strips and things like that, I can usually tell if you're ovulating or not regularly. Because ovulatory versus anovulatory fertility issues, we can already start to differentiate like what might be going on or what the cause might be just by that alone.
Yeah. And, sometimes I know for myself, I got obsessive with it, right? The tracking and when we were. So
absolutely,
actually just maybe keeping a calendar for me, that actually probably would have been better than an app, because I was so regimented about it. And I'm sure, listeners too. And there's nothing sexy about that with your partner when you're, trying your best to conceive and things like that. So
yeah. You're really, really right about that. It's something that I really try to, as the doctor, often because I'm a general OBGYN, often I'm the entree point into care or evaluation if it seems to be taking a little bit longer. And I want to be really sensitive to that because we don't want to put unnecessary stress on the relationship. I mean, we know it's stressful when you're trying to get pregnant and that it's not turning, you're not seeing that extra line on the test. We know that's stressful. But I'm trying to come up with some evaluation and productive, suggestions, but still encouraging, like, one of the things that I look at is if you are having those regular periods, and like I said, it doesn't have to be clockwork, but if, it's about a month, give or take, and it's most months that's happening, then we know that fertility people are generally most fertile about 2 weeks before their period comes on. That's it's like 12 to 14 days before we see the bleeding is when they're most fertile. So the variations in the cycle are a little bit more so early on. So if somebody has a 3.5 week cycle, then they will ovulate earlier in the cycle. If they have a 4.5 week cycle, it may be a week later in the cycle because it's the time from ovulation to the period that's more regular.
Yeah.
But what I try to encourage is really, you could do the strips, like 1 or 2 months if you want. But my biggest thing is if you're getting your period regularly, we know that you're ovulating. And so just and you don't have to time sex perfectly with the peak ovulation either. So I always say, if you have sex 2 or 3 times a week in that week that you think you're probably ovulating, the sperm will be there. It will be there and will be available. So that hopefully takes a little bit of that like stress, because we do, you're having the time with your partner that's special. And it's so hard, I know, because you're not seeing the result, but we don't want to make stress, and we want to, help that relationship, not pull away from it.
Right. Absolutely. Especially with every stage of this is, every month you're getting your cycle, that's a loss, and all of it. And it's already so emotionally draining. I know. And it's, during that time, you could both be grieving differently and just to try to come together and take away any external stressors that we can is so important.
Yeah. It really is. It definitely is. And that, if you feel like you have to have sex on that exact day, you might not have time that day. Like you might be busy, maybe work's crazy. Like maybe one of you has a business trip. You don't want to feel like you have to rush home or do something crazy. So there is flexibility there. Sperm can live up to a week in the female reproductive tract. Now, obviously, if you're trying to get pregnant, we don't want to rely on a whole week if we can avoid it. But I mean, definitely a few days is fine.
Yeah. Yeah. No, that's great to know. And, something else too is, and we talked about it right at the beginning and pre-show and everything, when it comes to infertility, everyone seems to have advice. It's like all of a sudden, you're saying like we're trying to conceive and then boom, like the insensitive, which with great intentions, you hope, all of a sudden comes out. And it's because, like I said, whenever you share infertility, it's just like you can almost read it on the survivor's face, because gosh, know what they're going through and just the exhaustion of it all. And it's, those myths are like, just relax and it'll happen. Or I knew this person, A, B, and C, and they went on vacation and came back pregnant. Or, it's just so much misleading. And it's deeply frustrating for those who are navigating infertility and it not being looked at as the disease it is. And it doesn't stop there. About questions with weight, exercise, PCOS, endometriosis treatment, surgery, diet. Yeah. So these myths can create so much of that confusion and guilt and distracting us from the real medical issues. So Allison, let's dive into some of those common misconceptions and, about the truths behind some of these claims and how we can separate that noise from the science with fertility.
Yeah, I think that's a really great thing to talk about. And so first I would just say, just in terms of the workup that we would do, just to sort of tie that together, some age can also be a factor. So we'll do if there's no reason to think there's infertility, like there's no history, and if because fertility for women especially can kind of gradually go down over time, age related, we kind of use 35 as a change in how long we try before we do an evaluation. And that's just an arbitrary cutoff. there's no reason to think, that for a lot of people trying to get pregnant after 35 would be, a problem. But we generally say you can try for up to a year if you're under 35 and there's like no pre-existing thought before you necessarily need the full workup. Of course, that's really hard because, like you said, every period feels like a loss. So I'm not saying like you have to wait a whole year to come in, but when, you don't have to necessarily come in as soon, because we do know it can take a healthy couple that long. So there's variability, and certainly, the first or second time you're trying and you see a period, that's super normal because it's human reproduction is so inefficient. But as people get older, especially women, because we can see a drop, we don't want to have somebody waiting a whole year to come in for assessment. So we usually say, 35 or older, come in if you've tried for 6 months, just because we know it's a little higher risk time frame. And then if you're 40 or older, we may even have a lower threshold. So really don't feel bad about coming in, even quite very quickly, just to discuss that and figure out if more is needed.
Yeah.
And we usually I'll do a small workup and then I can refer out. But myself, I'm always happy to do a referral right away if somebody would prefer to just do the whole workup, and if needed, any intervention with a specialist. I think it's fine to do a fair amount with your general OBGYN, but it's also totally fine to ask for the referral if you feel more comfortable. And do even the workup with a specialist.
Absolutely, Allison.
Yeah, but to go sort of talk about that myth of, okay, well, you're stressed, just relax, because I know that's a big one, right? People hear it all the time.
All the time. We're going on vacation. It's
right.
Like,
yeah. And we all know people who went on vacation and got pregnant. That's fabulous for them. But
good for them.
Yes, but I think it is really important to not blame something that's happening on stress, or like something like stress. That's really like a diagnosis of exclusion. And I mean, if somebody's not getting pregnant, even if we've eliminated like any condition, if it's been, that length of time, like a year or 6 months, and they're a little bit older, like it still falls in that category of unexplained infertility. So we do not want to just write it off as stress. Does stress make your body, could it affect your fertility? I mean, stress produces hormones like cortisol. It raises those, and it can make it a little bit of an less favorable. Your body, you have some inflammation, and it's a little bit theoretically maybe harder, but it is most certainly not responsible for infertility. I think it's probably more of now you're stressed on top of everything else that's going on because you're not getting pregnant. And blaming stress isn't going to help anything. Yes. So while I think that the doctors and the people supporting you, may advise that let's find ways to make this process less stressful. Like, for example, how I mentioned, you could do ovulation strips if you want, like a month or two, but that might be stressful. Let's not, let's try, or you don't have to time it exactly that day of ovulation. Things that can make it less stressful are helpful, but blaming stress for this and assuming that lowering your stress is going to solve infertility, that's definitely a myth.
Right, because you already feel like, for myself, I'll say, you feel broken, right? Like you're coming in, your body's not doing the one thing that we were programmed and designed and educated on since growing up to do, is natural of, making a baby and keeping them to term and then delivering. And when that doesn't happen, Allison, it's all of that, like overwhelming and just stressful, on top of it all, because it really is consuming your whole entire life and journey, when you're on it. So.
Absolutely. And I also think it can be a little bit dangerous for stress to get blamed. If you're having a regular monthly period and you're not getting pregnant, then, it needs to, we need to check and make sure the fallopian tubes are open. We need to make sure that the partner's sperm is normal and that it's moving normally, and that it's, that there's enough sperm to meet the egg. And And also something I saw, I mentioned that I worked with women who had ovarian insufficiency. We used to call it ovarian failure, but then we realized, well, that's a bad way to call anything, because now on top of everything else, people feel they're a failure and they're not. But I worked with women with ovarian insufficiency, and I talked to them a lot about their diagnosis process, because that was sort of my focus. And what we saw was that these women wouldn't get a period for like many, many months, or maybe they stopped getting their period altogether. And on top of that, their estrogen levels were low, which they didn't necessarily know, but they felt bad because sometimes they had hot flashes or they couldn't sleep well. And, it caused other effects on their body. And they were going in for care. And sometimes they were told, well, you're not getting your period because you're stressed.
Yeah.
That's so dangerous, because a young person should have a regular period. And if they're not, then we should figure out why they're not. It's not always ovarian insufficiency. It could be PCOS. It could be a thyroid problem.
Yes.
It could be what we call the athlete triad, which is when they're exercising a lot, or if there's an eating disorder. There's a lot of reasons, but all of those reasons are concerned health that have other effects on health and can be dangerous. So that's another reason why we really don't want to just blame this on like, okay, you're stressed, because if your body's not doing what it should be doing, and yes, like ultimately trying to get pregnant and successfully getting pregnant, but certainly if it's not having the period, or other, things, like we need to figure out
Exactly
where this is going wrong and what's going on.
Yeah. And it's interesting because we talk about this a lot in support groups, is that a lot of us, when we were in our teens and things like that with birth control pills, if we had painful periods, you were just kind of given a birth control pill and take this, and they didn't really do any further diagnostics. And, it was kind of chalked up. You almost felt like they were gaslighting you, like, oh, her painful periods, like her pain tolerance must be really low. When realistically it was, a lot more going on there until we were older now and finding it out through, cyst bursting or endometriosis, with having such pain, and getting off birth control. And then it's like, okay, now we can address these issues or find them. But a lot of that has happened too. I don't know if you've seen that, Allison, as well.
I see that so much. I mean, and I work with teens too, so I can see that spectrum. You're working with a younger person; they're not worried about pregnancy right now, and you're balancing. Like, you don't want to miss something that could affect their fertility in the future. You also don't want to, worry them too much. But I think that it is because I started with hearing, like my whole career with hearing stories of, in that case, it was people who maybe didn't have a regular period when they should have, and they were started on birth control. But I also hear that now a lot too, where it was like they were painful periods and they started birth control. So if something was wrong with the period when you were a teenager, the pill may well help it or even mask it, but there could be an underlying issue. And so I hear that a lot. Or people are just told kind of like, okay, your periods are really painful, just suck it up. Like, you're okay.
Suck it up, Bob. Yeah,
exactly. And then it's like, well, is your period painful? Like you take some Tylenol or ibuprofen and you're fine? Or is your period painful? Like you're missing school and work, you're throwing up, like you're in the fetal position. Like, I think that there's people who have really bad periods and they're definitely kind of poo-pooed about it. And then it turns out like later when they want to get pregnant that they do have endometriosis. So and I've been recently, I started, I'm as a GYN, I'm a surgeon, I do surgeries. And recently I started doing robotic surgery, which is great because I can see it's a tool that lets me zoom in more and I can do even better dissection with endometriosis. So I've been doing even a little bit more than I had been before with that. Wow. And what struck me was I've had patients who came to their post-op visit where we confirmed what we thought, which is, yes, there's endometriosis. Even if they weren't trying to get pregnant, like even if it's completely unrelated to fertility, just the mere fact that we have an answer as to why their periods are so painful. And they told me about it. I listened. we decided based on, you don't always need surgery to diagnose it. You can treat it and assume, but we decided to do the surgery. We did it, got it, diagnosis, got information. We have plans. We talk about future fertility, whatever it is. They're crying, just like, you heard me and we did this, because there's so much of that where it's just like, painful periods. Your periods are a little regular. Like,
I
just.
know. We like preach from the top of, rooftops and mountains that, validation and feeling seen and heard by your physician and by, survivors who get you, whatever, is so important in your healing journey, and just to continue to process and work through everything that's happening around you in these moments. Right,
It's
Allison?
huge.
It's so true. Yeah.
It's really huge. And I don't want to make it come off like negative about colleagues or anything, because I think that we are all like learning as we go through our careers. And I think like a lot of learning is going on in women's health, like in the last couple of decades, especially. Like we've learned so much about things like irregular periods and painful periods. And there are so many OBGYNs out there, especially like my generation of OBGYNs is more women than men. And male OBGYNs can be amazing because sometimes they're like more sensitive because they can't physically feel it. But I do think that there's a lot of empathy in our generation of OBGYNs, but there's definitely also sort of this history of many generations ago of OBGYNs being more like patriarchal and not kind of getting it as much. So I would say that I want to say that even if there was a bad experience in the past, there are so many OBGYNs that are out there that would be so happy to help and listen. And it's just a matter of finding somebody who wants to help and listen.
Yeah, because there's so many fellows, fertility survivors out there who want to be a part of their care and want to feel like they're a part of a team and not just being told what to do. It's, to try to have some sense of control, because we're feeling out of control and not having anything to really grasp onto. So it's nice when we are part of that care team. Yeah.
Yeah, absolutely.
Yeah. So what would you say about weight and exercise and diet? I would love to hear your take on that, and I'm sure our listeners would too, Allison.
Yeah. And also by way of background, like I'm board certified in obesity medicine as well as OBGYN. So it is a hot topic for me. I work with a lot of people on weight loss and healthy diet and exercise. And so what I would say is, one is, we do know that if the weight is higher, it can affect fertility. It can, and sometimes that is part of this chicken or egg process of polycystic ovarian syndrome, but not always. So PCOS, polycystic ovarian syndrome, is a condition where people have, their ovaries have lots of little follicles. So they're not really true cysts, like people have cysts that rupture, things like that. They're little tiny follicles, but there's a lot of them. And they have periods are spaced out significantly, like more than that. 3 to 5 weeks is pretty normal. So often they can go a couple months without a period. And sometimes we'll see signs of high testosterone, like extra facial hair or hair on the back or the chest. So having two of those three things, so either periods spaced out, ovaries look polycystic, or higher testosterone levels, meets that diagnosis. But what it is it is associated with insulin resistance. So often we'll see that their bodies have a harder time processing sugars, and going hand in hand with that is there can be a weight issue. And so, but we don't always know, if you have a higher weight or more sugars in your diet, and that's environmental, because especially here in the United States, we have higher sugars in our diet. And that's just part of the environment we're in. And some people's genetics don't work as well with that as others. But so with PCOS, sometimes we don't know, is it the condition that's causing the weight or the weight that's causing the condition? Sometimes people will say, okay, lose weight, and then we'll talk about fertility. I don't know that that's helpful, because it's stressful. And then it's just kind of this is a condition, like any kind of weight issue. There's so much prejudice around it that I think a lot of times people have really suffered from being just kind of told like lose weight. Well,
Right.
lose weight's not just a thing you can just do. Like
Wow.
if it was that easy, most people who are suffering from this would have lost weight. Like most people who are heavy have been on a diet many times. They probably have all sorts of exercise regimens. If anything, they may have been pushed towards disordered eating because they've had so much like do this, and then eventually it kind of fails, and then it's the cycle.
It is.
So
It's a vicious cycle,
yeah,
especially when food is your comfort, even
right.
if, you know, outside of an eating disorder and things like that. And you turn to that, and then all of a sudden it's just like fueling the problem even more. Or if baking and cooking and, you know, give you the joy that you're looking for and experimenting, right, Allison, it's like a double-edged sword almost sometimes.
Right, exactly. You don't have to have this eating disorder or even disordered eating to have some emotional eating, which may not be best, but it can, you know, it's sort of all part of that. Yeah. And
But
food
it
is
sounds like a
comforting.
spiral. Yeah.
We all know. I mean, I'm Jewish. We grew up like, you know, you don't feel well or whatever. You get chicken soup with matzo balls, like whatever. Like that's how it is. You know, food is comfort. Yeah. So, I mean, can losing weight be helpful for fertility if there's a weight issue? Yes, it can be. We also know that pregnancies where somebody has a higher level of obesity, if they have higher weight, it can be more dangerous. But that said, like, you know, it's something that you don't, I think that we don't want to mask like evaluation for something that's going on by just blaming it on weight. So that's a big thing because, you know, people will come in with like, you know, shortness of breath and they happen to also be heavy and they'll be told like, it's your weight. Well, I mean, maybe like their weight's contributing to whatever's going on, but they're short of breath. Like, let's not, and I'm like literally using this as an example because like this happened to my sister. Like, I mean, like you're not like, yes, sure. Yes. Weight is probably a factor in all of this, but right now, like you're short of breath. Like, let's deal with that. And then also separately, let's talk about ways that we can help support you with weight. And let's not say diet and exercise and see you next year. Like that's not helpful.
Not helpful. And it's like that holistic approach because, like weight or diet could be a factor, but it's not the only factor that's tying into this. And that's, you know, and it's really doing a thorough workup to really see, you know, what it is. And two, you know, our hormones are so out of whack, right? Like, you know, Allison, we're saying, and with PCOS and things like that, and maybe having more testosterone, like just when your hormones are out of whack too, it doesn't help with weight gain or loss. And it does affect you too. So it's just, it's so much all at once.
Right. So, and it's tricky. So I think it's hard, but I think that anybody who says, oh, it's your weight, doesn't, you know, take that history, talk about everything, do a workup, like you might need to push for a little bit more of a workup or find somebody you feel more comfortable with. By the same token, like if you have a higher weight and it can affect your health, don't be offended if the doctor wants to talk about it or address it, as long as they're sensitive about it. If they're saying like, oh yeah, you know, weight and you need to diet and exercise and figure it out and whatever, that's not that helpful. Or if they say something that, you know, makes you feel bad about yourself, like that's not the goal. But you know, if they offer you ways to kind of help with the weight, that's good. We do now have more tools than we ever did to help with weight because we have these newer medications. But I will say that we've had other medications in the past that are also really helpful. And the thing that I think is most helpful is, you know, finding somebody who can give you ongoing support, because what happens with like our traditional diets is you can lose weight with them because that's how they work, but they also fail because your leptin and your ghrelin, your hormones that regulate your weight, will go in the opposite direction. And basically what happens is your body's metabolism drops. Like you get pulled, you have this rubber band that kind of pulls you back up because your metabolism drops when you lose weight. So medical weight loss is like either adding medication or whatever we do. Sometimes people will even have bariatric surgery, but we basically, sometimes depending on where the weight is and if there's underlying conditions or none, sometimes you don't need that. But when you work on medical weight loss, very healthy approach to it, we can kind of release the tension on the rubber band so you're not constantly getting pulled back up. Because if you lose weight but you're getting pulled back up, like that's harder. And so it's a little tricky with fertility because the medications that we have that can help support weight, sometimes they require we don't want you to get pregnant while you're actively on it.
Right.
So it's also a discussion to have, is like, should I try to lose weight like a bigger amount of weight, in which case I might need medication to help support me. I might need to take a break from fertility, or am I at a point where it's not best for me to delay fertility and I should, eat well, exercise, do some maybe weight loss until I see that potentially that positive pregnancy test, but not stop trying. So that's also a conversation to have.
Right. Because like fertility really is such a quiet loss. A lot of people don't know you're going through it unless you share it, because it's not visually seen. But then also it's a steamer pot too, because we all know, age is a factor. And as you get up, so it's like, you feel like you're in this time constraint of when you can have children. And it's, looking at what is manageable and what's feasible for me to be able to do or change in my life, lifestyle wise, or what that looks like. And it's having the right care, right? Having the right provider who you connect with, you trust, and you just can leave it in their hands, right, Allison?
Right. And there are some things we can do while you're trying to conceive. Like I have a patient that I'm working with who's on weight loss medication because she's delaying a little bit because she's going to go through IVF and she wants to drop a little bit more weight before she pursues that. I have another patient, that I'm working with who does not want to delay, but while she's trying to get pregnant, we're working on healthy diet, exercise. And in her case with some PCOS, we're using like some metformin off label to help her with the insulin resistance. That's like an on-label treatment, but it also can off-label help with weight loss, and it's safe with pregnancy. Yeah. So we kind of work, if we know and we have that open communication and they know that, yes, weight loss may help the fertility, but also like, I'm not judging, like this is like not, this is a medical issue like any other. And we kind of relieve some of that sort of, because there is that, long history of medical sort of prejudice towards weight, until we kind of relieve that by this is just a supportive environment. We can figure out, do we want to delay like the one patient, or do we want to move forward? But like in the meantime, just kind of give support. So if you don't get pregnant, you can continue take it month by month with that. Yeah.
And it's all about scalability and sustainability, right, Allison? So you can be told these things all day long, but if you can't keep it up and you just keep yo-yo diet, or whatever the case is, but it's having that care plan holistic with, and it being geared towards you and who you are and what you're actually going to do and not do, and making it, that it's not that we're, eating this huge elephant, we're taking bites at a time. Right.
Right. Yes.
So, and having someone like you in your corner and really customizing it, listening to what would make the most sense for them and what they need, it's huge and so important.
Yeah.
So I can't thank you enough, Allison, for everything that you're doing for survivors and for, maternal and women in general, with all the care that you're giving.
Thank you. Yeah. I think it's just about, like you said, like one day at a time, kind of also letting yourself experience, you're living with a loss. So you're, like you said, taking those bites, feeling, enjoying, living, all of that.
Yeah. Right. Oh, thank you so much, Allison. And is there anything before we wrap up that you would like to share with our audience who's out there facing fertility challenges or supporting someone on this journey?
Well, I know you asked about, you mentioned maybe a little bit about exercise too. And I would say my thought would be, during this time frame when things are difficult, if there's a way you like to move your body, do that. So if it's nice to go outside and see the sunlight, do that. Or if you I know when I struggle with situations or like, like different traumas, but things, dance. I'd like to put on my playlist of like, I don't care, whatever, make your own playlist and just like dance, whatever it is, or, that you like to do. Moving your body is just, it's healthy, but it's also, it can be such a release of just stress
really
and strain, or maybe it's yoga or meditation or whatever.
Yeah. Mindful movement or dancing,
right.
like you say, freestyle. And I know I jammed out to so much music after, my husband and I, when we were going through our journey, just because it gave me a way to almost like dance. Like there's a reason why people do rituals during grieving and things,
right.
different because it really does, like, you just release so much, and then you get to sing and almost like yell sing, where you're also like getting it out, and just a healthy release, right?
Yeah, absolutely. That release. Journaling can be helpful too.
Yeah.
And I'm so happy that we connected, and to like that you do like what you're doing, just bringing people together to have that support, and figuring out, having support groups, and also the people in your life that, that are there for you. One thing, I read this great book called Platonic about friendship. And, one thing that I learned from that was that there's that friendships, I grew up kind of thinking like, okay, so you do this for that person, they do that for you. That's how friendship is.
There's like a transaction almost.
Right. But reality is that, a real deep friendship is going to be like, that, but on a much longer term scale. So it's like, if you're going through this and your friend, maybe your friend is.
Oh, you froze. Yeah.
Sorry, I don't know. So you're going through, if you're going through this and you have, friends, sometimes it's, one thing I had to learn is sort of that you have to be, you can take and you can give. So a lot of us are like givers, as women especially, but like learning to take, and like, if you're going through this, or like, I had a friend who was like, my best friend like went through fertility treatments, and it was so disappointing, when she got, she used her last embryo, and we were just like, and I didn't know what to say.
Yeah.
But like, just being there in whatever way they need. So giving, but also taking, like, if you're going through this and you have a good friend and they want to let them take in whatever way that they will, that you like, let them know if there's something they do that you like, and remember that it's not like you did this, they do that. This is a time where you're struggling. Don't be afraid to take, and then take a couple of times in a row. Like, this is your time, and let them know. The best thing you can do for that friendship is letting your friend know how they can help you. So,
almost like training, because you need to like go off, everybody's going off your lead, right? So taking control of your care, and always like supporting all of that, and like really having them learn, like, or telling them up front, like, today I'm here, like, this is the spot I'm at mentally, like, I'm raging today, or tomorrow I'm feeling like I just want to like isolate and stay in my bed, like, but allowing people and bringing the right people in to tell them. But why deprive them of the opportunity? Because we know how good it feels when we get to help somebody, right? So why deprive somebody else that opportunity who loves you, who wants to be there and help you and support you during this journey, like you said, Allison, because this is temporary, right? There'll be an end at in your journey with fertility and things like that, and trying to get pregnant. But in the meantime, these years, you need your village, you need your community, and that's us, that's your support systems, and we're here to educate those support systems on how to truly support somebody,
and be real. Like, don't feel you don't have to go and tell the cashier at the grocery store what you're feeling. I mean, you can if you want. I don't care, I don't judge, but like, with your real, like, with your like close family and your close friends, it's okay. Like, if they're really close, like, they kind of want to know, like, today's a bad day, and I could just use it. Like, it's okay. I want to cry today. Like, or
Absolutely.
whatever, if somebody's good at whatever they're good at, like have them, they make really good, treats. Like you feel like having a treat today and they bake really well. Like let them know, I'd love to have your brownies again. They were fabulous.
Yes.
Yes.
Exactly. I know. And it is like, let them in, let them take care of you or whatever that looks like, but to be there for you because it
Yeah.
helps them too.
Yeah.
Yeah.
When it comes to the doctor stuff, since I know that's my area, what I
Right.
would say is a couple of things. One is find somebody who will listen.
Yeah.
Somebody that you're comfortable with, that you think like will listen to what's going on. They don't have to necessarily be like a total expert in what you're going through, but if they're open to listening, if you want to, get a second opinion, or you want a referral, or, you're interested in seeing a fertility specialist, that's, most of us are like, I'm general OBGYN. I can do a workup. Sometimes I'll even do some ovarian stimulation, but,
Wow.
ask for the referral. We're fine with that. And you can even, you can get a second opinion and come back. If you say they recommend surgery, I recommend surgery for endometriosis, but you're not sure, see somebody else, or even have your surgery at a tertiary care center and then come back and see me and I'll support you. Totally cool. So don't be afraid to explore those kind of options of second opinions and things like that. Because most of us are going to be like, yeah, you want to go to like an endometriosis specialty place at, the university and, couple, like the state university, it's a little trip that you are up for that.
Yeah.
That's awesome. So ask for the referral, explore, but most important, have somebody in your corner that like will listen and, help you figure out what's going on.
Oh, great. Oh, well, thank you so much for that advice for our listeners. Allison, thank you for being here, for
Thank you.
sharing. Yes. And thank you so much, all of our listeners, for tuning in. Please follow and subscribe to our podcast to help us reach more survivors. And we're always with you, infertility, pregnancy loss, and infant loss survivors. Until next time. Thanks so much again, Allison.
Thank you so much for having me.